Welcome to this Step 3 review on anticoagulation in practice, brought to you by Roadmap to Residency. Today is not about reteaching the entire clotting cascade. It is about the handful of question patterns that anticoagulation loves to test and exactly how to attack them on exam day. We will cover warfarin management and target ranges, the direct oral anticoagulants for atrial fibrillation and venous clots, the reversal agents, and how to handle these drugs around surgery. Keep your question bank and a trusted review resource open beside this video, because these patterns lock in only when you drill them. Let us get started. Here is our plan for today. First, you will learn to recognize an anticoagulation stem within the first few lines and move directly to the decision the question is actually testing. Second, we will build pattern recognition for the 4 highest yield areas, warfarin targets and dose adjustment, choosing a direct oral anticoagulant for atrial fibrillation and venous clots, the reversal agents when a patient is bleeding, and how to stop and restart these drugs around surgery. Third, we will work through several board-style questions together and explain exactly why every answer choice is right or wrong. This video assumes you already have the baseline pharmacology from your review resources. We are here to sharpen how you take the test. Our first strategy is to read every anticoagulation vignette by hunting for 2 things, the numbers and the verb. Start with the numbers. These stems hand you a target ratio, a kidney function value, and the time since the last dose for a reason. Your first job is to decide whether each value is inside its goal window or outside it, because that judgment usually settles the answer before you even reach the options. Then read the last line for the verb. Is the question asking you to start a drug, hold a dose, reverse the anticoagulation, bridge around a procedure, or simply continue what the patient is on? A stem about active bleeding is a reversal question. A stem about an upcoming operation is a timing question. Name that verb first, then go find the choice that matches it. Do this every single time, and these questions become far more mechanical than they look. Strategy 2 is the warfarin target mindset, and this is where a lot of points are won or lost. First, know the goal window cold. For most patients on warfarin, including those with atrial fibrillation or a venous clot, the target ratio sits in a familiar lower range, while a mechanical heart valve pushes that target higher. The moment a stem gives you a value, label it in your head as below goal, at goal, or above goal, because that label points you straight toward increasing the dose, holding, or reversing. Second, adjust for bleeding and for interactions. A value that is only modestly above goal in a patient who is not bleeding usually calls for holding a dose and rechecking, not for dramatic reversal. And stay alert, because a huge share of warfarin questions are really drug interaction questions in disguise. A new antibiotic or antifungal can drive the ratio up, while certain foods and drugs pull it down. Spot the interaction and the answer often reveals itself. Now let us talk about the direct oral anticoagulants, meaning when and why to reach for them. First, favor the direct agents for most patients. For atrial fibrillation and for most venous clots, these drugs are first line because they need no routine blood monitoring and carry fewer interactions than warfarin. So when a stem describes a clean, straightforward new diagnosis, the direct agent is usually the answer the test wants over warfarin. Second, know the firm exceptions, because the exam loves them. A mechanical heart valve and moderate to severe narrowing of the mitral valve are classic settings where a direct agent is simply wrong and warfarin is required. Pregnancy and significant kidney impairment also change the choice, so let those details override your default. Third, let kidney function screen the choices. The kidney value is planted in these stems on purpose. Poor clearance can make a particular agent unsafe and push you toward a different drug or a lower dose. Before you commit, always check whether the kidneys quietly rule out one of the tempting options. Let us work through our first practice question, and this one tests the warfarin target mindset together with a hidden interaction. A 70-year-old woman on warfarin for atrial fibrillation feels completely well. Notice that she was started on an antibiotic 5 days ago, which is the interaction hiding in plain sight. She has no bruising and no bleeding, her vital signs are normal, and her ratio today is markedly above her usual goal, sitting around 6. The question asks for the most appropriate next step. Before you choose, label that value as well above goal, and note the crucial fact that she is not bleeding. Read the 4 options carefully, pick your answer, and we will reason through each one together on the next slide. Let us break this down step by step. Step 1, spot the pattern. Her ratio is well above goal, yet she has no bleeding at all, and there is a brand new antibiotic that neatly explains why the value climbed. That combination is an asymptomatic elevated value driven by a drug interaction, not a bleeding emergency. Step 2. Apply the rule. For a ratio that is elevated but without significant bleeding, the correct move is to hold warfarin, withhold a dose or two, and recheck the value, letting it drift back toward goal. Aggressive reversal with plasma is reserved for serious active bleeding or for far more extreme values. Step 3. Eliminate the wrong answers. Giving plasma and intravenous vitamin K treats a bleeding emergency she simply does not have, so it overtreats. A large oral dose of vitamin K while continuing the same warfarin swings her too far and ignores the interaction. Continuing the dose unchanged ignores a value that clearly needs action. The correct answer is to hold warfarin and recheck. Notice how labeling the value and checking for bleeding pointed you straight to it. Here is our second practice question, and it is all about direct oral agent selection for atrial fibrillation. A 68-year-old man is found to have new atrial fibrillation. He has high blood pressure and diabetes, which raise his stroke risk, and the STEM tells you that risk score is clearly high enough to warrant anticoagulation. Crucially, his kidney function is normal, he has no valve disease, and he would rather avoid regular blood draws. The question asks for the most appropriate long-term choice. The key is to confirm he needs anticoagulation, then rule out any exception that would force warfarin, and see whether the STEM is nudging you toward a monitoring-free option. Pick your answer, and we will reason through every choice on the next slide. Let us work through this answer. First, screen for exceptions before anything else. The STEM quietly clears every setting that would force warfarin. There is no mechanical heart valve, no significant mitral narrowing, and his kidney function is normal. Once those are ruled out, you are left with a standard atrial fibrillation patient whose stroke risk is high enough to require anticoagulation. Now, why does the direct oral agent win? It is first line for atrial fibrillation because it needs no routine blood monitoring, which lines up perfectly with his wish to avoid blood draws, and it carries fewer interactions than warfarin. Look at the distractors. Aspirin alone does not meaningfully protect against stroke in atrial fibrillation, so that is a trap. Choosing no anticoagulation ignores a clearly high-risk score. Warfarin would technically work, but with no exception present, it is not the best fit, and the STEM even hints at the monitoring downside. The correct answer is the direct oral anticoagulant. Now let us tackle reversal agents, which is the bleeding emergency pattern. First, match the antidote to the drug. When a patient on any anticoagulant has serious bleeding, the question almost always comes down to which reversal agent fits. For warfarin, urgent reversal means vitamin K together with a clotting factor concentrate that replaces the missing factors quickly. For the direct oral agents, remember that the thrombin inhibitor has its own specific reversal agent, and the factor blockers are reversed by a separate dedicated agent. Learning those pairings cold turns a scary question into a simple matching exercise. Second, and just as important, confirm the bleed is truly serious before you reverse anything. Reversal agents are reserved for major or life-threatening bleeding, or bleeding into a dangerous space such as the brain. For minor bleeding or simply a high laboratory value with no real bleeding, the right answer is usually to hold the drug and support the patient, not to reach for a costly antidote. Always judge severity first, then choose. Here is our third practice question, and it is a reversal emergency. A 75-year-old man on warfarin for a mechanical heart valve is brought in after a fall, and imaging shows bleeding inside the skull. He is drowsy, his ratio is well above goal, and he is deteriorating in front of you. The question asks for the most appropriate next step. This is the mirror image of our first case. Here there is life-threatening bleeding into a dangerous space, so the whole calculation changes. Think about what reverses warfarin fastest when every minute counts, and be wary of any answer that is too slow or too passive. Choose your answer, and we will reason through every option on the next slide. Let us break down this answer. First, judge the severity, because that is the hinge of the whole question. We have bleeding inside the skull, a patient who is drowsy and deteriorating, and a ratio well above goal. That is life-threatening bleeding into a dangerous space, and it demands immediate, complete reversal rather than any form of watchful waiting. Second, choose the fastest correct reversal. For a major warfarin-associated bleed, the standard is a clotting factor concentrate that replaces the missing factors within minutes, given together with intravenous vitamin K so the correction holds. Now the distractors. Vitamin K given alone takes far too long to work when the patient is bleeding into the brain right now. Holding warfarin and rechecking in the morning is dangerously passive and could cost him his life. Transfusing platelets does nothing to fix a warfarin problem because his platelets are not the issue. The correct answer is the clotting factor concentrate plus intravenous vitamin K. Notice how correctly grading the bleed as life-threatening drove the entire decision. Here is a high-yield exam day pearl that ties the whole topic together, and it is anticoagulation around surgery. Think of it in two halves. Before surgery, stop the anticoagulant far enough ahead that its effect has worn off. And remember that with the direct agents, you must adjust that timing for kidney function, because poor clearance means the drug lingers. Then ask the bridging question. Is this patient high enough risk that they need a short-acting bridging agent while the long-acting drug is stopped? Many atrial fibrillation patients do not need bridging, whereas a mechanical heart valve very often does. And for truly minor procedures, sometimes the right answer is simply to continue the anticoagulant. After surgery, restart anticoagulation once the surgical bleeding risk has settled, which is often as soon as the next day for lower risk procedures and deliberately later for operations with high bleeding risk. The board answer always weighs the danger of a clot from waiting against the danger of bleeding from restarting too soon. Let the bleeding risk of the specific procedure set your timing, and these questions become far more predictable. That wraps up our review of anticoagulation in practice for Step 3. Remember the core patterns we covered. Read every stem by finding the numbers and the verb, and label each value as below, at, or above goal. For warfarin, an elevated value without bleeding usually means hold and recheck and watch for the hidden drug interaction. For atrial fibrillation and most venous clots, favor a direct oral agent unless a firm exception like a mechanical valve forces warfarin. In a bleeding emergency, grade the severity, then match the antidote to the drug, and around surgery, stop early, consider bridging only for high-risk patients, and restart once the bleeding risk has passed. The best way to lock all of this in is to drill questions under timed conditions and read every explanation, and to confirm the current target ranges and dosing in a trusted, up-to-date review resource, since this guidance is refined over time. Visit roadmaptoresidency.com for expert tutors and residency advisors who can help you build a personalized study plan. If you found this video helpful, please like and subscribe so you do not miss our next board review session. Good luck on your exam, and we will see you in the next video.